Mode.
Hello, everyone. My name is Giovanni Nogales, and I am a paralegal here at Laos Parker. Welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled Building from Baseline, Practical Advice for Strengthening Your In-Home Health and Hospice Compliance Program. Today's presenters are Richard Pecore and Regina Morano. Just a quick reminder, if you have any questions throughout the presentation, please feel free to type them in the chat box and we will address as many as possible at the end of the presentation. So without further ado, I present your speakers, Richard Pecore and Regina Morano.
Thank you, Gio, and good afternoon, Richard, and good afternoon to all the folks who are joining us this afternoon. We're really always so happy to be with you. It's one of our favorite groups to work with, and we certainly appreciate the opportunity. We just want to briefly introduce ourselves. As Gio said, my name is Regina Morano, and I am exclusively a healthcare compliance and regulatory attorney, lots of experience also in transactions, but focus on compliance and regulatory matters. I really worked the first half of my career in New York State in a variety of regulatory and private sector positions. I've been affiliated with Laos Parker now for just over 5 years as an of counsel, and I also retain a nearly full-time position in-house with a biotech company. I do have direct experience working with home health and hospice. I worked with one of the largest Blue Cross Blue Shield companies in the state of New York that also ran affiliate home health and hospice organizations. So I do have that experience as well, but essentially an all-around healthcare and compliance attorney. I'd love to introduce you to Richard. I know you're familiar with him. And Richard, if you don't mind, would you mind just sharing some of your background as well?
Sure, Regina. Appreciate it. Thanks everybody for having us here. My background, I've got about 7 years in on asbestos and silica litigation. I work with lung injuries, personal injury, that sort of thing. And then I came over to the healthcare side and have been here for the last dozen years with Laos Parker, mostly working big box cases. I've handled claims anywhere from $15,000 on the smaller Medicaid side to $6 million on the Medicare side. And now we're focusing a lot on third-party billing contracts, regulatory compliance, and administrative appeals.
Wonderful. Thank you so much, Richard. And we do have a disclaimer. We are obligated to share this with you. The presentation is provided as general information only. And legal advice, strategies, and outcomes will vary greatly depending on your own particular facts and circumstances. Therefore, please remember that this presentation does not constitute legal advice or create any attorney-client relationship. If you do believe you need legal advice on a particular matter, please seek out and hire competent legal representation from a licensed healthcare attorney in your state. Thank you. And we'll move on to the overview. We just want to give you a quick overview of what we're going to cover today. Remember that the topic today is building up from baseline. It's practical advice for both Richard and myself on how to strengthen your in-home healthcare and hospice compliance program. The intention is to talk about in some detail the guidance that the Office of Inspector General, OIG, has given us around having that basic compliance program, but also the other ways in which we can build off of that and do the best we can to protect ourselves, in particular in situations where there may be some enforcement action, some action on the part of a payer. And that could involve anything from a desk audit to a subpoena to a search warrant or investigation and the fallout from all of that. We always want to emphasize the importance of exclusion screening for individuals, and some of the key, particularly the key federal and similar state healthcare fraud and abuse laws, such as the Stark Law and the anti-kickback statute, An important compliance tool that we all should be familiar with is self-disclosure protocols when you do find that you potentially have been overpaid. Of course, HIPAA, some of the main principles of HIPAA and a couple of updates on that. And really of particular focus and concern with our home health and hospice clients, patient abuse or neglect, risk issues and advice around that, and then ultimately some advice around resolving problems that may come up. That's essentially what we're going to cover today. I'm going to take the first part of the presentation, and always, of course, welcoming Richard's input, but I'm going to go over the first number of slides with you. So regardless of what your regulatory or enforcement situation is, as I said, whether that is a desk audit, a records request, or something all the way up to a subpoena or some kind of an investigation from law enforcement. When that sort of drops on your door, whether that's an email, whether that's a letter that comes in the mail, whether that is people knocking at your door or showing up in your office with a search warrant, whatever the nature of that is, do not panic. There is a path. There is always a path. There is a process. There is some order that you can bring to this. So just take a deep breath. Before you even think about what you're dealing with, sort of the always be ready principle, you really should always be ready to know who are you going to reach out to and who are you going to partner with in the event that you have, as I said, anything from a record request to a desk audit to something much more serious, such as a subpoena or a search warrant or a government authority showing up at your door. Have a sense of who you're going to call, whether that starts with a colleague, your own compliance officer, whether that is bringing in your CEO and your more senior leadership. If you have an in-house counsel, know who your in-house team is and know who your outside resources are. And understanding that most of you are located in Texas, think about who are your local Texas law firms that you might be able to reach out to assist you in the event that you one of these things drops on your desk or at your front door. In terms of in the moment, understand who and what you're dealing with. So if you have an on-site situation and you have someone knocking at your door or delivering a subpoena, figure out who you're dealing with. And certainly if you have a live person there, ask them for ID if someone is showing up on your doorstep there. Get copies of whatever they're requesting. Make sure that you get copies of it, whether that's a subpoena or whether that's a record request that they're walking in and handing you. Make sure that you make copies of it. Figure out, are you dealing with someone from the government? Are you dealing with someone from the Medicaid Inspector General's office? Are you dealing with someone from CMS? Is it a contractor perhaps? Is it a MAC? Is it a commercial health plan even? Because, commercial health plans have special investigation units that can really end up bridging over into even, government investigation or criminal allegations. So figure out who you're dealing with and whether, whether you are dealing with the government in particular or, just as serious, you need to take just as seriously a commercial investigator as well. Richard uses this phrase, stop the bleeding. And that means if you have any clue about what they are looking at or investigating, take some steps right away to pause or stop whatever it is that they look like they're concerned about. Whether it's even billing a certain code or whether it is the way that you are onboarding patients or how you are certifying folks for hospice or how you are handling plans, whatever it is, take a pause, figure out what are they looking at and let us look at it and figure out before we do any more of this, let's figure out whether we're doing this correctly. And again, if you're dealing with a subpoena or an investigator calling you, knocking on your door, sending you something, call your attorney. If you haven't done it so far in this imaginary scenario, give them a call and for two reasons. First of all, hopefully you have a good attorney and their advice is going to be helpful and good for you. But also, all the communication and all the steps that you're taking, you want to make sure to the extent you can that you place all that under privilege. And the only way you really can do that is by engaging your attorney in the discussion and hopefully working at the direction of the attorney going forward. So the other thing too, if you're gathering documents for a subpoena or a record request, make sure that you make a copy of everything you're pulling and everything you're preparing to turn over. Can't tell you how many times we've seen clients, you know, they'll be really good. They'll meet the deadline. They'll pull all the records that are necessary. They'll batch them up and ship them out the door or have them delivered. And then realize they didn't keep a copy of anything. And so that's really critical, that you make sure you have a copy of everything that you are turning over. And also, you know, depending on the nature of what kind of an inquiry you're looking at, you probably want to give your insurance carrier a call, because first of all, sometimes there is coverage. Whether that's, you know, under your D&O coverage or other types of coverage with your carrier, malpractice or D&O, whatever it is, you'll want to talk to them about it. But if you don't notify them and it turns out later that there may have been coverage, you might have waived your ability to access that coverage. So that's always a good step to sort of, in the heat of the moment, as early as possible, get in touch with your insurance carrier. And then above all, you know, never ignore it. Don't let it sit for too long. Don't try to rationalize it away. Don't try to minimize it to your higher ups. Deal with what's in front of you and don't ignore it. So that's our advice on first steps. And then, you know, sort of the longer term, we give advice around, you know, your best defense is a very strong compliance program that you build on over time. So I think we're all relatively familiar with these 7 elements of what the government thinks believes is an effective compliance program. And it starts really with good written standards of conduct, your compliance policies and procedures, your code of conduct, making sure that you really do have everything outlined for your workforce and your leadership so that everyone knows what is expected in terms of compliance behavior and compliance conduct and policies, and that they meet the requirements of the OIG, the Office of Inspector General. You really should, at this point, have those policies in place, at least your baseline policies. And over time, you know, you really enhance that inventory. You should be reviewing those policies every year and strengthening them and, you know, using the insight that you develop on your own over time, advice that you pick up from your advisors and consultants as well, to strengthen the policies and procedures. You certainly should have a compliance officer and a compliance committee made up of your corporate leadership, your company leadership. And that should be a functioning compliance officer and committee, not really using someone and giving them that extra hat to wear, but really have a true compliance officer with the right kind of training and the right kind of expertise and the ability to communicate and organize all of this for you. And of course, your committee really should be plugged in and should be active. And so, you know, choose wisely the folks that you place on your compliance committee. And then another required component of an effective program is education and training. So really what we're doing today is really helpful. Good training for everyone in the field, really everyone throughout the company, whether that's management, leadership, whether those are the providers who are actually out in the field, the providers who are handling referrals, the folks who are handling your claim. Everyone really should be getting effective compliance training throughout the year. And then there's this language around having effective lines of communication. And really what that means, a bare minimum, is having that compliance hotline in place so that there is a place where the workforce can go, your healthcare partners can go to report potential violations or concerns, or reach out and say, hey, I need I need help understanding something. I need advice on how to do this correctly. It's not really just supposed to be for complaints and violations. It really should be a place where people can go and say, hey, we need better information. We need a better process. All of these things. It should be really an improvement, a continuous improvement tool. And then this idea of enforcing the compliance, the conduct and the standards through well-published guidelines. That means not just that your policies are located someplace and are dispersed to your teams and all your workforce, but also really at this point in the evolution of healthcare, we really should have compliance conduct and compliance standards and goals really baked into the job descriptions. And that's an important step. A lot of providers have taken that step. And I think at this point, really OIG looks for that. And it's important to do it. And then really a significant piece of an effective compliance program is having a monitoring and an auditing work plan and doing routine auditing around things like adequacy of your medical records, substantiating medical necessity, the overall integrity of your claims, your coding practices, whether or not your coding is at all of those sort of particularly billing related and documentation related standards. You should be actively monitoring and auditing for those. And that leads right into item number 7 there, which is promptly responding with corrective action around any findings that you may come upon in your auditing and your monitoring. So that's the foundation, really. And then we want to talk about, the next thing we want to talk about are some of the risk factors that are particular to home health agencies and particular to hospice as well. And some of these overlap to a certain extent. I mean, certainly I think by now we all know that it is prohibited to offer financial incentives for referral sources. So that means, giving away gifts or fancy dinners, or in any way incentivizing the physicians and the hospitals and the other providers who refer to home health, really strictly prohibited. Very, very minor exceptions around that, dropping off some coffee or a couple of bagels once in a while, in connection with some compliance related matter or some educational related matter. That's about the only thing that's acceptable anymore. The Stark physician self-referral law, really very important with respect to home health, because the Stark law, as I think Richard may get into a little more detail later, but the Stark law has to do with physicians who self-refer for other services. So, if you have a physician-owned home health agency, or you have a physician, a member of a physician's immediate family who owns a home health agency, very, very strict laws prohibiting referrals between the two. So from the physician or the physician's immediate family to a home health that one of them may own. Joint ventures, very, very tricky. Never enter into a joint venture without expert legal advice around those types of transactions. The referrals between joint venture partners are fraught with risk. And then, we can't emphasize documentation enough. Certainly, sufficient documentation of whatever services were performed. This is particularly sensitive in home health, where there isn't, the home health takes place in the home, in the community. So it's not in an environment like a hospital or even a physician's office where there is sort of more direct oversight over what's going on. So all the more importance to including very strong documentation of the services that are performed. And really the number one risk factor for home health around as far as the government is concerned, and as far as the focus areas where the government is consistently over years auditing have to do with insufficient documentation of medical necessity. Home health services must be justified medically as medically necessary, and if the documentation isn't there, then the medical necessity is not there. And they're just so good at auditing for this that it's critical. It's critical to be a master of documenting medical necessity. And then additional documentation requirements around making sure that those patients do qualify as homebound, and making sure that you're not billing for something that was not rendered. You know, the home health care provider or worker may go into the home fully intending to do 3 or 4 specific things in a day, perhaps run out of time, or perhaps it becomes obvious that a particular service wasn't necessary or wasn't going to be appropriate that day. So really important to be very careful not to bill for what was intended, but for what was actually delivered, and making sure that that's documented. Of course, medically unnecessary services, you know, you may be able to document that you did it. You may be able to have a rationale for why you offered a particular service, but if it wasn't medically necessary, that's a risk. That's not a valid service to bill for. And then, of course, I want to skip to inadequate or substandard care. I've seen a couple of home health agencies come very close to losing their license around things like wounds that were not properly attended to, and even things that might seem, you know, somewhat removed from the actual direct care, such as even bag technique. You know, being observed by Medicaid personnel, and bag technique not being consistent with requirements, with patient safety requirements. I've seen deficiencies around that, and I've seen home health agencies get into some significant trouble just around bag technique. And then, you know, home health coordination. You know, there are a lot of unallowable costs sometimes that home health entities try to bill for, and just be careful that you're not trying to bill for that. And certainly in any healthcare area, duplicate billing is prohibited, obviously, whether that's an error or whether that's something intentional. And then moving on to some additional risk factors on the next slide. The cost reports, you know, sort of having your financial house in order. The cost reports, making sure those are accurate, and on the credit balances, not just, you know, running your credit balances every 6 months or a year, but running your credit balances on a routine basis and making sure that you're refunding and reconciling those balances. And then again, another area particular to home health risk is overutilization and even underutilization of services. And that relates not just to potential fraudulent billing on the overutilization side, but certainly sufficient patient care on the underutilization side. This issue of billing for services that are provided by unqualified or unlicensed clinical personnel, you know, I think you might be familiar. There's been some significant activity around fake nursing licenses and diplomas. I think you've had that right in your backyard in Texas, and we're starting to see a lot more emphasis around that nationwide. So making sure that you are checking those credentials on not just coming in the door, but the renewals on a routine basis, and making sure that your clinical personnel are appropriately certified or licensed. Backdating amendments or falsely dating amendments on the nursing notes, padding or falsifying plans of care later on after, you know, an audit comes in the door. You know, signing for a physician or falsely certifying the plan of care on behalf of a physician. Do not take liberties in that area. That will get you into a lot of trouble. You know, this is happening, forging beneficiary signatures, whether that means the nurse or the aide forgot to get the signature, or whether that means that that's a routine practice on the part of the nurse or the aide. High risk. That's criminal activity as well as a threat to the validity of your claim. I'm getting a message about whether or not you can hear me in my audio. Can you guys hear me? Can someone just let me know if you can still hear me?
Yeah, I can hear you.
Okay. All right. Also, improper patient solicitation, high pressure marketing. OIG and the government don't really care for direct solicitation of patients, and particularly sick patients or elderly patients. So I would keep that to a minimum. That's always my advice. And then if you're using subcontractors, you have to really stay on top of your subcontractors, not just the delivery of services, but to make sure that billing is proper as well. And then there is a pretty good amount of attention, an ever-evolving amount of attention being paid to whether or not, home health or other providers are being discriminatory with regard to admitting patients, whether they're cherry picking patients or trying to push patients out who they view as undesirable, either based on the coverage or any one of many discriminatory reasons. Be very careful of that as well. And then we have actually quite a number of additional risk areas for home health. I might have to run through these a little more quickly, but I'm on slide 9 now. Some of this, again, keeping your financial house in order, making sure that you're not billing for unallowable costs if you're involved in the acquisition or the sale of an HHA. Steer away from compensation programs that offer financial incentives for higher number of visits or higher amounts of revenue, squeezing more visits into a day or coding higher than the documentation supports in order to be paid more or bonus. Those are really risky areas. Sort of misusing provider certification numbers, saying, well, we're going to bill under this provider's number, or sort of this borrowing other provider certification numbers in any field, home health or hospice or any field. Very, very dangerous game. And then be careful that you're not duplicating services that might be provided by an assisted living facility or a hospital or physician or other home health agency. When folks are in home health, whether it's a discharge from a hospital or it's a longer term issue, there is a lot of coordination of care that goes on, and the government is just not going to pay for the same service being provided by multiple agencies. So what else do I want to emphasize here? Certainly make sure that your licensing requirements are always met, and check in on the conditions of participation on a routine basis, and make sure that if you are accepting Medicare, that you are in compliance with those conditions of participation in your provider agreement. And then I did want to say a word on overpayments. Overpayments, it's not just a matter of if you find it, make sure you pay it back. You really should have an overpayment policy that outlines how you're going to routinely surveil for overpayments, who's going to be responsible for that, and what your process is going to be when you find a potential overpayment, how you are going to evaluate and assess that and determine whether you have an overpayment, how much that amounts to, and making sure that it does get repaid. It's really not enough anymore. This is the idea of building on baseline. It's not enough just to pay it back if you find it. You really need to be routinely auditing and surveilling for that. So very important on the overpayment piece. So I think we are going to move over at this point to some of the hospice area. on slide 11 and the next couple of slides. And, some of this does overlap with the risk factors for home health, but some of these are unique to Medicare hospice. So, a decision for a patient or the patient's family to move the patient from some kind of routine care to hospice level of care is a huge decision for families. And the government is very, very sensitive to making sure that the family and the patient, whoever is the decision maker or the proxy, when that decision is made to elect that Medicare hospice benefit, that there is truly informed consent to do that. Also very sensitive, the government's very sensitive to moving patients to hospice care as a way of, saving money or as a way of filling the hospice bed, either way, but admitting patients who really are not terminally ill and can't be certified as terminally ill. Again, this issue of coordinating care at the hospice level, making sure that, if there are multiple providers involved at that point in the care process, that duplicate services are not being provided because they are not reimbursable. Underutilization of hospice care, when hospice care is truly in order and it is not utilized, a patient isn't transitioned to that level of care, government is sensitive to that as well, to leave a patient in a different level of care when that's not the right level of care anymore. Falsifying the medical records or the plan of care, there's a pretty good amount of scrutiny on plans of care in this phase of government enforcement. So make sure that what is in the medical record and in the plan of care is not exaggerated, and that those records and those plans are developed by the appropriate licensed personnel. Again, with the forged signatures or the signatures that are provided later by physicians, moving someone to hospice without the physician certification and then getting the certification later, or filling in the blanks on the plan of care later, is a high risk area for hospice. And then inadequate or incomplete service or insufficient oversight of the patients. Sometimes there may be a tendency to over rely on the family and leave the family to its own resources and not really provide the level of care that's expected of the hospice team. Those are high risk areas as well. And then a few more issues on risk factors for hospice. Again, the issue of, I'm on slide 13 now. Billing for care that's provided by an unqualified or unlicensed personnel. You have to make sure that your folks are licensed and the license and the certifications are up to date. This messing around with amendments later to substantiate something when an audit comes in the door, conforming an amendment to inquiry that's made based on medical necessity or some other component of a records request, very, very high risk. And again, as I mentioned a couple of minutes ago, the government really does look with disfavor, particularly on where vulnerable patients and families are concerned. This high pressure sort of direct marketing, either to at-risk vulnerable folks or to beneficiaries, frankly, who are not eligible and wouldn't meet the standard for hospice care. And then again, if you're using subcontractors, making sure you have strong enough oversight of the service itself and the billing. Really be super careful around any sales commissions that are based on how long someone stays in hospice and making decisions around who gets in based on how long they might be there. And then, being too loose, not having good, strong oversight over your volunteers, and making sure that, hospice can be delivered almost anywhere in this day and age, but making sure that you have your location and your place of service clearly documented in relation to your claims as well. So, Richard, I can take this this last slide here on 14 about what's a payable claim, but please do feel free to jump in. Essentially, pulling together everything we just talked about in terms of risks, you have to make sure that the service and the supplies were medically necessary, of course, that they were actually provided, that there weren't any other statutes that you were violating, for example, using unlicensed personnel or bringing patients into your program, based on improper incentives, et cetera. Making sure that you have it down cold, what the eligibility and the coverage requirements are, and making sure that those are met for each and every claim in each and every case. That medical service and supplies are fully documented. That your codes are proper. Don't squeeze that to the next code if the medical record does not support it, certainly. Making sure that your claims are clean and properly billed, and on the back end, making sure that they're properly paid. And if they're not properly paid and you're overpaid, work up your overpayment process and make sure that your overpayment is reconciled. So I'm going to stop there. I know Richard has a lot of advice, and I'm just going to get out of the way at this point and turn it over to him.
Regina, thank you so much. And I want to emphasize to folks, I got a little bit of an echo here, that she just covered the meat of this, and we're giving you kind of a 10,000-foot view on this for a lot of the big pieces of the compliance plan. And I need to spend a few seconds just telling you why it matters, because we talk about compliance plans being your first line of defense, and it's not just talk. The reason is the appeal rates have decreased so much with such a hostile environment in the courts and with contractors that success rate now is generally run around 12% or so. Now we have a higher percent success than most. But the point is the odds are against you. And the problem with that is that the number of home health agencies and hospices continue to decrease. Profits are down. You need a way to even the odds. And the way you do that is by avoiding getting into trouble with audits or attracting unwanted attention. That's how you stay profitable. You stay out of business. Your compliance plan is going to help you do that. It's a tool. You need to use it. And your billing contract is the other half of that. So let's talk about a few things here. Let's talk about the billing contract. And I'm not going to spend as much time on this because there are some other things. You may have noticed in Regina's section that a lot of these specific reasons that were listed in both the in the section she's talking about for both home health and hospice had to do with blocks of ideas. Your first move, if you have a problem with an audit, a subpoena, an overpayment, or an excluded individual, you need to have your attorney on speed dial. If anything like that comes up, that's your first move. It's not going to be self-disclosure. It's not going to be an overpayment and rush to return it in the first 60 days. First, you got to figure out if you got any more of them. So you need someone to help you get a handle on the problem. Like Regina was saying, is so important. There's always time. This is the law. Nothing moves fast. It might in the beginning, but then it's going to hurry up and wait. So you have time to get your ducks in a row. You have time to talk to your attorney and figure out what your next move is. The other thing that happens is you look at the regulatory law violations, you look at your coding and billing silos, you look at your policies and procedures, your patients, your employees, and your contractors, your procedures as far as protecting your patient information, that sort of thing. All this comes into play. And when you know the basic building blocks are okay and you're keeping tabs on them, it helps you work everything else to the specific factors that make your entity, your home health agency, or your hospice peculiar, and what's going to help keep you out of trouble. So examples of things you want in your contract: you want a termination provision. You want to be able to get out of the contract, because if you're a provider and your biller is there, you may need to get out of the contract too. You don't want to have a biller on the hook that you got to pay. They may not get paid until you do if you're on prepayment review. But the problem is, it's another bill you got to pay, and you got to pay them a big chunk. So you want to cut them loose as soon as possible until you can get your suspension or your payment hold cleared up. Refunds, credentialing, what's the provider going to give you as far as the information you request? They have a duty to provide that to you. They should have a duty to cooperate in there. The coding needs to be full and accurate and complete information. Anything you request, you should be able to get. The HIPAA compliance and the establishment of mutual compliance efforts needs to be a joint effort with feedback. And then you've got your insurance responsibilities that needs to be spelled out. You're going to have E&O, you're going to have cybersecurity. Are you going to have legal defense insurance? That's a choice. It's not a requirement for the contract. Next slide, please. Thank you, Gio. More provisions that should be in the contract. Billing companies write periodically, visit on sites. Now, why? They want to be able to give you feedback and see if there's something they can't figure out what's going on. They're going to need to see the process. And it always helps to have a third pair of eyes. And if you're doing everything above board, that should not be a worry to you. Responsibility for maintaining direct facsimile numbers and secure emails. You want to have good comms. The business associate agreement is essential. It's required by HIPAA, so that's something you've got to have in place. Basically says your contractors are going to abide by HIPAA compliant, high-tech laws, the things that are federally and state required, and you have to have it. So you want to have that contract built. No responsibility to bill claims where insufficient or ambiguous support. That's part of your termination provision. If you're not going to get supported, you need to be able to get out. And this goes back to the audit provision. One of the things you can do is, if you have resistance during an audit, if you have stonewalling going on, that should be a huge red flag to you as a biller that maybe your provider's got problems. As I said, from the provider point of view, if everything's okay, then this should not be a worry. You should be looking forward to this as someone that's going to actually do this for you. And it's a huge headache. So they're going to take their time and do it and help you figure out what's wrong. A compliance addendum that gives an overview of every party's responsibilities for everything from background checks to other compliance efforts. Basically, it's going to spell out from the parties who's going to do what. Next slide, please. Billing agreements, federal limits, they're spelled out there in 42 CFR 447.10F. Basically, the Medicaid is going to pay the provider directly, except in the one strange narrow reassignment situation. Claims are reassigned to a biller directly. And in that situation, that narrow situation, and I've only seen one client that was in this situation, percentage-based billing agreements, PBAs, are prohibited. Other than that, the Fed does not ban them. Now, state laws are a whole different story, because you got 50 states, 50 state laws, plus you got DC, Puerto Rico, etc. Yeah, basically, you got to choose carefully, because every law is different. Some states prohibit them entirely. New York's an example of that. California is pretty much wide open. They do have 2 or 3 exceptions, things like chiropractors. Different states have different quirks, but basically the majority of them, 33, 34 now, have some sort of restriction on percentage-based agreement. And that's the big bugaboo because it's based in the law of fee splitting and the fear that billers or the chasing of money is going to lead to the sacrifice of medical treatment, good quality care. So chasing the almighty dollar is not what we want to do. Next slide, please. Was this care medically necessary? For post-payment audits and suspensions, basically look at the documentation for the claim before you send it in. We're going to ask the same questions we did before. Was it medically necessary? Is there evidence of the services provided? Were there services provided? Were they received? Any statutory violations that stand out? Is there a referral problem that you've got to deal with? Have all the coverage requirements been met? It's been properly coded, properly billed? This goes back to the elements of a payable claim. This is something that helps you deal with these sorts of claims when you look at the most frequently cited denial reasons. This goes back to medical necessity being the #1 denial reason for OIG year after year after year. If you're in home health, if you don't document fully as much as you can your medical necessity, you're begging for that claim to get kicked back. And if you do it routinely in the same way, clone notes is the biggest problem with that. If you don't add something new to make each note unique, it's a clone note. It can lead to a pattern of fraud. And now you've got a lot bigger problems. Percentage-based agreements, again, the problem with this is you don't want to enter into that type of agreement as a provider if those types of agreements are prohibited for your medical discipline or altogether in your state. For instance, if you're in New York, you just can't do it. Now, I'm not sure the law actually says that, but the state attorney general enforces it that way. So until somebody gets a whole lot of money and wants to try to contest this, or the legislature takes on the question, which I don't think is going to happen anytime soon, that's the way it is. Hourly based agreements, flat fee agreements, per claim based agreements, all those are okay. You can use those anytime, anywhere, any state. The big bugaboo is percentage-based agreements because, again, that goes back to the fee-splitting bugaboo. Next slide, please. So post-payment audits and suspension, this is going to be kind of the same, only this is after the fact, and this is where the appeals come in. Your assistance will likely be needed to pull, analyze, etc. the documentation. You want to look at that. But the biggest thing is to make copies. I mean, like Regina said, we can't count the number of times that you get help pulling all these records for an auditor or a contractor, and you don't have a copy of what was made. That's happened to me on at least 2 occasions and on some pretty big audits. And the problem is they spend so much money trying to recover and recopy everything. It's easier electronically now in some cases, but usually to really work the file, you still need paper, and that's expensive. So again, do it on the front end. Can you terminate the contract if payments get delayed? Again, from both the biller and the provider's point of view, you don't want to have a contract that's going to be in suspension for 6 months, a year, 18 months. It could happen. How you get paid if the Medicare payments are being recouped? Well, it's going to take time. And whose fault is it if a claim is improper? Why is the claim improper? Will the provider allege that the billing company is at fault? Sometimes. What happens from the auditor or contractor point of view? In all honesty, most of the time, third-party billers, they don't go after it because the third-party biller doesn't have the money. It's the provider. The provider is ultimately responsible. The biller is a contractor. They are an agent of yours. They are an arm. And that's going to bring up something else I'm going to talk about in a minute, which is offshoring. But I want to come back to that. Do you have E&O insurance? If not, why not? And don't forget your obligation to repay any overpayment within 60 days. Next slide, please. Okay, the suspension part of post-payment audits and suspensions, that can happen based on a credible allegation of fraud. That's all it takes. Usually it's a 6-month minimum, but it could go all the way up to 18 months unless you can test it. Provider can continue to see and treat Medicare patients during the suspension, and they can continue to bill for services, but they're not going to get paid because the money's going into escrow. So what happens? You have a cash flow crisis. Well, what do you do about that? You start minimizing costs. Again, you cut your biller loose. You see what happens. You contact your attorney. You try to start jumping on this in a hurry. From the biller's point of view, you're looking to get out of it again. Should you terminate the agreement? How long are they going to be in limbo land? Again, 6 to 18 months. You have no idea because there's no real process for that sort of appeal. What's the risk? Again, we talked about that. If you're a billing company or you a target, you could be. If you're caught up in a fraud ring, there was a whole bunch of providers, I think there were home health agencies that were up in the Dallas-Fort Worth area when they did the last raid up there. I think this is actually 3 or 4 years ago. And they took down something like 79 home health agencies just for being associated with this huge fraud ring that they brought down. So yeah, it's possible. Be careful who you get in bed with. There it is at the bottom there. Rockwall, Texas. This is 2012. $375 million, 78 DFW area home health agencies had done business with them. And a bunch of them got excluded. Next slide, please. Subpoenas, search warrants, investigations, and fallout. Get a copy of the document. You're going to have to show it to your attorney. He's going to be able to tell from the type of document it is as to whether this is going to be criminal or civil. And Robert had a way of saying this. It's not to belittle it. He says if it's civil, it's just money. We can deal with money. Money's not going to take away your life. Money's not going to put you in jail. Call your attorney as soon as you can. If it's a subpoena, you may have some more time to respond, but your attorney needs time. Usually the first thing they're going to need to do is see what it is and then see if they can get more time to respond. If it's a search warrant, do not get in the agent's way. Do not block them. You will be arrested. You will be taken to jail. Okay? You don't necessarily need to help them, but you can't obstruct. So, be sure to take notes on exactly what they take. So if you have the opportunity to make copies, do that. If it's law enforcement, you may not have that opportunity. You'll get an inventory. Do you have a business interruption contingency plan? Do you have a policy that spells out and says what happens if? It's something you need to think about. Be prepared to release a public statement reviewed by your attorney. Train your staff to deal with questions. In other words, don't talk and do not give interviews. There's an example of Marina Healthcare Group, January 2018. They had $5,000 in kickbacks for referring hospice patients. When the investigation began, he called the individual who gave kickbacks and told the individual to lie to the FBI. First, he called him directly. So there's a phone record of the call. And he says, lie to the FBI. So now, that's out there in a win too. When the physician was interviewed, he also lied and denied accepting the kickback. So the indictment was unsealed January 2018, and that was scheduled for July 2019, but there was a conviction there. So don't lie to the FBI. Nothing good's going to happen. Next slide, please. Exclusions. Exclusions are huge because this is the death penalty. First of all, you're obligated to check it monthly. Most state laws require this now. You're required to do so in Texas. Every provider is required to participate in Medicaid, and the Texas Provide Trading Partner Agreement for Medicaid requires you to do your exclusion checks monthly. And this includes the OIG list of excluded individuals and entities, the LEIE list, there's the link, the GSA, which is now called the SAM, which is the System of Awards Management Exclusion System. That's the other government, it's for government contracts. The Medicaid exclusion list in Texas, that's at the HHSC website under OIG. And there are Medicaid exclusion lists in every other state. Understand that if you are excluded anywhere from any federal program in any state, you are excluded everywhere. And that means if someone comes to you and says that, oh, I was excluded, but it expired. It never expires, never. They are not hireable. The only person that could be rehired is someone who submits an application to HHS and they approve it and give them a written letter, say you've been readmitted to the program. If they cannot produce a written letter from HHS that says everything is okay and you can now participate in the healthcare industry, they are not hireable and they are lying. And you can get in a whole lot of trouble because if they are employed by you, they're going to taint every single claim that you have filed during the tenure of their employee. So there's no telling how big it could get. I'm not going to cover this special advisory bulletin. This is back in 2013. It's how it started. Provider actions. Check the LEIE, SAM, and state exclusion lists. Do it every 30 days. How do you prove a negative? If someone's not there, how do you prove that? With screenshots. Or you can hire a service. There are lots of services that can do this affordably if you can't afford to, if you're a one-horse shop, if you don't have the time, or if you have too many employees. Consider a service. Biller actions, they should do the same. If you have contractors, you need to check them out as well as you can, and they also need to be under business associate agreements. You should already know that. What happens if we did use an excluded individual? What did we say a little while ago? What's your first call on speed dial? Call your attorney. You may wind up utilizing a self-disclosure protocol procedure, but your attorney's going to need to figure that out first because it is a minefield. And there are certain things you need to do and accomplish first before you just jump into that, because lots of bad things can happen along the way. You could wind up far expanding your liability more than you ever intended to, and you do not want to do that. Get your attorney involved immediately. Overpayments and CMPs, well, again, you got 60 days from the time it was discovered, but that's the old question, how big is the elephant? So there, again, you're going to get your attorney involved because first thing you're going to need to do is an audit to see how big the elephant is. Is it just one overpayment or do we have a whole bunch? Civil monetary penalties, they could come along the line if an excluded person participates in any way in the furnishing of items or services payable by federal healthcare programs. So not only can there be problems with the excluded individual just from tainting all the claims and creating a huge overpayment, but you could have civil monetary penalties on top of that, and those can get very large. So it's not a laughing matter. It's something very serious. You need to take it very seriously. And again, this is one of the action items where you have your attorney on speed dial and you say, what do I do? That's all you need to ask him. This is what happened. This is what I have. What do I do? He'll take it from there, or she. The OIG Special Advisory Bulletin also states a provider can reduce or eliminate its CMP liability if the provider is able to demonstrate by exercising due diligence and following up that it reasonably relied on the contracted entity to perform the check of the LEIE for the employees of the contracted entity. In other words, if you hired a service and you're relying on them to do the job, you're entitled to do that. So again, that's another reason to have one. Next slide, please. I'm going to skip the cases here. Y'all can read those if you want. Next slide, please. Billing for services not provided. More case examples. Let's skip that. I think we're right at the end here. Self-disclosure, you're only going to use that if you have a situation like we've discussed. You're going to have to contact your attorney first anyway. I'm going to skip that for now. It's in very narrow circumstances most of the time. Next slide. HIPAA, BAA, you know what a BAA is. It's been around for a long time. It says you're going to comply with HIPAA law, everything else. The only thing I want to mention here is that offshoring is something that's happening more and more. Providers are hiring offshore billing services. Even billers are hiring them. Here's the problem. There are about 8 states where that's illegal. You cannot export PHI offshore. Florida's one of them. They just did it most recently. Federal government doesn't do that. They have not outlawed it. But some state governments, including Texas, have restricted them for state contracts. So there's about 8 states that say no, none at all. There are about 10 more that say it's restricted, and that's for state contracts, or you got to give us notice that you do offshore. The only protection you have is in your contract, because once the data goes overseas, you've lost control of it. So you've got to have contractual protection. But if you're in India, for instance, there's a 25-year backlog list in the courts. Be careful who you sign a contract with. Next slide. I think we're close to the end here. Forgive me for going long. I'm not going to talk about breaches. That's standard stuff. Y'all can read that. Next slide, please. I think we're close to the end. These are the CMPs as of last year. It's on a percentage scale now, but you can see how much the maximums are and what the caps are on the tiers. When you have civil monetary penalties, it can get really expensive. $63,000, $64,000 a pop is a lot of money. Next slide. Patient abuse and neglect. I wish we had more time to cover this. Regina, do you want to say anything about this?
No, I think one thing I guess I'd emphasize the 2 points on the slide there, Richard, is that there is an obligation to report, and home health providers are required reporters. So if you have knowledge or you suspect abuse or neglect, you do have to report that. And HIPAA is not an impediment. HIPAA does not prevent you in any way from reporting that abuse or neglect. And also, if you do report something in good faith, you do have the protection in general of the law. You can't be subject to any kind of liability for that.
Okay. Slide 31. Resolve the problem. We've covered pretty much what we wanted to say. You see that the big thing in red here is call your legal counsel. You're going to get attorney-client privilege. It's going to protect all your discussions. You're going to be able to devise a legal strategy. You're going to be able to deal with the fraud if it's discovered, and see how big and deep and long it goes. And billing companies are on the periphery. If you're a provider, you just need to get them involved as soon as possible. Anytime you have a significant legal problem, that's my advice. And I think that's our last slide. Do we have any questions?
Yeah, there's a few questions, actually. So one question is, my insurance broker has told me that there are no policy for coverage regarding caregiver fraud. What insurance coverage are you referring to when calling them to verify coverage?
Well, E&O insurance mostly, errors and omissions.
I think maybe what the carrier is saying, and again, we're not insurance experts, but maybe we could suggest how to probe this further with your carrier. You wouldn't have coverage if you did in fact commit fraud, but you certainly should have coverage under errors and omissions or malpractice, or your D&O. If you're accused of fraud or you're being investigated for it, and it turns out, of course, that you didn't commit a fraud, then you should have coverage for that whole process. But I think it's a little bit of a semantics that your carrier might have shorthanded their answer to tell you you wouldn't be covered if you did commit fraud.
That's a great point, Regina. It's a little unclear there, but yeah, it's the insurance is business insurance, basically, is where you're going to go with that. And if you should have coverage if you wind up coming out the other side and you're not going to jail.
Okay. The second question is, can you elaborate more on the statement of sales commission based on the length of stay?
Yeah, I mean, there's a risk in paying sales commissions. For example, you would get a commission or a higher commission if you bring us a patient that has maybe a longer term prognosis and is going to fill that bed for a longer period of time, for example.
Okay. The third question, this is a hospice question regarding signatures at the end of every visit. So it says, what is the actual requirement? In hospice, the patient cannot always sign for themselves, but a caregiver or other healthcare facility worker may not be available. Any advice on this?
Gina?
Yeah, I think you have to annotate that as patient unable to sign. And then the rest of your documentation has to be able to support that you did provide the service, that you showed up and whatever service you provided during that visit was actually provided.
Okay, that was the last question. That concludes. You can go ahead.
I'm sorry. I was just saying I appreciate the opportunity to be here with everybody. And Regina, thank you for coming, taking time out of your busy day.
Thank you, Richard. It's always such a pleasure to present with you. And we really do love being a resource for the folks at the Texas Home Care and Health and Hospice. So thank you for your hospitality as well.
All right, so that concludes today's webinar. Thank you for joining us, and thank you to our speakers, Richard Pecore and Regina Morano. Everyone from today's webinar will receive copies of the presentation slides via email tomorrow. If you have any other further questions about today's discussion or another healthcare law issue, please feel free to reach out to Lyles Parker. Have a good Wednesday and take care.